Hello, everyone. My name is Giovanna, and this is my comprehensive care project. My patient is a 62-year-old white female. She is married and works as a motor vehicle representative. She is 5'2", 135 pounds, and has a BMI of 24.7. My patient came into the clinic with the chief concern of my back tooth hurts when food gets stuck or when I get poked at the dentist. Medical conditions include hypertension, depression, anxiety, and stress, seasonal allergies. She's also postmenopausal and has a past history of anemia and gestational diabetes. Medications include a half tab 25 milligrams hydrochlorothiazide. This has no effects on dental treatment, bleeding, or use of local anesthesia or vasoconstrictors. My patient does state that she often forgets to take this medication. She does have a family history of hypertension, breast cancer, and neuromuscular disorders, and her last physical exam was September of 2019. Here are her vitals. As you can see, blood pressure was very high at every appointment. She does have dental anxiety, which I believe is a contributing factor, along with the fact that she does not take her medication regularly. That being said, I did refer her to her doctor for a physical since it has been 2 years. All other vitals were within normal limits, but because of her stage 2 hypertension, I categorized her as ASA 3. Extraorally, my patient presented with bilateral crepitus and a deflection to the left. She used to be a chronic cheek chewer and admits to clenching her jaw. She does have an occlusal guard, but does not wear it. Intraorally, she is missing number 5, 12, 21, and 28 due to ortho, as well as her third molars. She has a class 1 occlusion all around and a slight open bite on the right lingual side. Maxillary free gingiva was generalized pink, firm, bulbous, and smooth. Attached gingiva was generalized pink, firm, and shiny. Mandibular free gingiva was generalized pink, firm, bulbous, and smooth with a localized erythematous border on number 24 facial, and the same for the attached gingiva. Plaque index was 84.6. MBI was 20%, BOP 4.8%, and she had a Cout code of 4 medium. Probing depths were generalized 2 to 3 millimeter pockets in the anterior teeth, were generalized 4 to 5 millimeter pocket depths in the posterior teeth, and localized 6 to 7 millimeter pocket depths in the mandibular left posterior teeth. There's a class 1 furcation and number 30 buccal, class 1 mobility in number 24, and 2 millimeters recession on the buccal surface in number 19 and 20. Attachment loss was generalized 1 to 2 millimeters and with a localized 3 to 4 millimeters interproximally. After assessment, it was discovered that there was mucogingival involvement. What was previously recorded as a 3 millimeter pocket is actually a 4 millimeter pocket, and her attached gingiva was measured at 4 millimeters, which puts number 24 in the mucogingival involvement class 1 category. This also explains the red erythematous border around number 24. Here are my patient's x-rays. She came in with the above x-rays that were taken at her last dental exam, which was 2 months prior. Since the bite wings did not have a good image of the maxillary bone, the dentist prescribed 4 new bite wings, which I took on the bottom. Looking at the x-rays, we have a 1 to 2 crown to root ratio. Bone loss is in the coronal 1/3. There's generalized horizontal bone loss with localized vertical bone loss. There is not a significant widening of the PDL. And there are no active caries. Her last one was 40 years ago. She has all amalgam fillings, class 1 on number 3, 15, and 18, a PFM on number 14, and a root canal and PFM on number 19. If you can see, the crown on number 19 is invading the biologic width, which has created a local factor. For all these reasons, I have classified my patient as AAP stage 2, grade A. I determined my patient's oral hygiene skills to be poor. She only brushes 1 time a day for 30 seconds using long horizontal strokes. She only likes using a manual toothbrush. She does not like the feeling of an electric toothbrush, and she only flosses once every few weeks. So my patient is pescatarian, and her diet was high in refined carbohydrates, low in protein, and higher in saturated fats. And given that my patient is postmenopausal and an older adult female with a past history of anemia, I focused on fiber, iron, calcium, vitamin D, and vitamin B6 and 12 for her. I recommended she increase her fruits and vegetables and replace a high carb snack with a high protein snack instead. I also recommended that she lower her sodium and increase her water consumption because of her hypertension. Here's her carbohydrate analysis. She had 20 minutes a day of daily liquid exposure and 160 minutes a day of solid acid exposure. I determined her caries risk to be moderate. She does have obvious plaque, and her teeth and gums do bleed easily. She also has deep pits and fissures. However, she does have fluoridated water and uses a fluoridated toothpaste. For OHI recommendations, since she prefers the manual toothbrush, we went over a modified Bass technique, and as well as C-shaped flossing. I also recommended a water pick for her because she sometimes gets food stuck in her restorations. And I also recommended a proxy brush for the mesial of number 19 so that that crown doesn't cause any further destruction. For fluoride recommendations, I recommended she continue use of her fluoride toothpaste and to incorporate a fluoride mouth rinse. And I also encouraged her to drink more water because more water equals more fluoride. Treatment plan was a 4-quad SRP with local anesthesia. We started assessment on October of 2021 and started treatment in November 2021. We started off using nitrous because of her dental anxiety, but she stated that she didn't need it anymore. And we ended treatment in January of 2022, and the reeval was in February of 2022. And her future maintenance plan was set at a 3-month recare. Post-treatment outcomes, we had a decrease in pocket depths, decrease in MBI, decrease in BOP, and unfortunately, there was an insignificant plaque index decrease. It only decreased by 2%, so that was a little disappointing. Pocket depths, there was a generalized increase in pocket depths by 1 to 2 millimeters, which is what we want to see happen. The area that showed the most improvement was the mesiolingual reading of number 19, which went from a 7 to a 5. But since this pocket depth was as a result of a local factor, it was determined that Arrestin would not help this area. Here's the post-treatment plaque index, which pretty much looks the same as before, unfortunately. Patient compliance, the patient did not consistently brush her teeth 2 times a day. She, however, did start using the modified Bass technique and incorporated a fluoridated mouth rinse in her routine. She increased flossing from 1 time a month to 1 time a week, and also started using a proxy brush once a week. Determined my patient's prognosis to be poor, mainly due to her 82% plaque index score post-treatment. Brushing and flossing definitely needs to improve here. I focused my research on 4 topics, starting with biologic with invasion. The research stated that invading this space causes injury to the periodontium, including increase in inflammation, BOP, recession, pocketing, bone loss, all which we saw with this patient. I also researched the association of perio with hypertension among postmenopausal women, as well as the effects of stress and anxiety and depression. Both produce pro-inflammatory cytokines, which alter the host immune response and the body's ability to fight off perio. I also researched mucogingival involvement and causes of it, such as crowding. So what happens is the buccal tooth movement takes the teeth outside the alveolar bone, which may create dehiscence and fenestrations, which cause the gingiva to migrate apically, and then we get recession. An interesting experience for me with this patient was her dental anxiety and hypertension and how that led to changes in treatment. I had to adapt. For example, with maxillary injections, I wanted to do the big 5, but given her anxiety, I determined it would be better to do only 2 versus 5 for her comfort, which she handled well. Some days I also did not use epi because of how high her blood pressure was. And I also did not use ultrasonic because of her anxiety, since she said it caused more anxiety for her. What I learned more about mucogingival involvement. I always assumed that recession had to be present with it, but that's not always the case because with this patient, there was no recession. I also got to see the effect of the invasion of biologic width, And I also learned that motivation is key for a positive outcome. Overall, this was a great learning experience because I got to see the importance of what we do as hygienists. Not all results will be positive, but I did see some improvements in my patient, and that was very rewarding to see. Thank you.